Hi, I'm Mike Contos for CardioSource. Today I'll be talking with Dr. Alan Jaffe, a well-known national and international expert in cardiac biomarkers who is currently Professor of Medicine at the Mayo Clinic. Today our topic is, are serial changes in troponin useful for differentiating ACS from non-ACS causes, and are they useful for early diagnosis of MI? Alan, it's now being increasingly recognized that troponin elevations are common in many conditions other than acute coronary syndrome. What are the ones that are most frequently seen?
Well, the ones that are most frequently seen are those that are in patients who are critically ill, whether they're hypotensive, hypertensive, tachycardic, most of them relating to supply-demand abnormalities, the effects of catecholamines, for example, in patients who are hypotensive. So it's the critically ill that probably have more frequent elevations. That said, as assay sensitivity is increasing, and as you know, high sensitivity assays are coming soon to the United States and there have been released elsewhere in the world, we're starting to see a lot of structural heart disease also manifest modest changes and modest elevations in cardiac troponin, whether it's due to heart failure, renal failure, diabetes, left ventricular hypertrophy, and the like. We're also finding that a variety of drugs do this, such as chemotherapy, much of which is cardiotoxic, including things like carbon monoxide poisoning, etc. So there are a large number of insults to the heart that evoke cardiac damage, and obviously with it an adverse prognosis that we're starting to unmask. The more sensitive the assay, I would suggest, the more frequent those are going to be. But the biggest group for now are the critically ill.
And as you alluded to, do we need to care about these elevations if we identify a non-acute coronary cause for the elevation? Are they prognostically important?
In almost every study that they've been looked at, they are prognostically important. That is to say, they're prognostically important short term in predicting who's going to survive. And just to take the critically ill as an example, those individuals who have an elevated troponin are at markedly increased risk when they're critically ill. And it's probably not rocket science. This probably relates to the fact that if you're sick as stink with multi-system organ failure and your heart's involved, it's worse than if you're sick as stink without your heart being involved. But in addition, after these patients go home, if you take survivors, those who had elevated troponins are at markedly increased risk. And the first set is hard to deal with because we're not sure what to do with the patient who's septic, for example, to reduce the risk associated with the elevated troponin. But once those people recover and go home, we ought to scrutinize them to see if they have some simple things like coronary artery disease, like valvular heart disease, like hypertension, hyperlipidemia, the sort of preventative things that we do routinely and ought to do routinely when we have a risk marker like troponin.
Given the frequency that we're seeing these elevations with the newer, more sensitive assays in non-ACS patients, is there a way to differentiate the elevation from an acute coronary cause or a non-acute coronary cause? People have talked about using serial changes or relative changes. Are they useful?
Serial changes are useful, but not for the sole distinction of coronary versus non-coronary causes. Acute causes, whether they're due to, say, pulmonary embolism, which causes acute myocardial injury, or sepsis, which can cause acute myocardial injury, or acute myocarditis, or ACS, will give you a rising pattern of values. Whereas the more chronic elevations that are associated with structural heart disease, be it coronary artery disease, left ventricular hypertrophy, heart failure, renal failure, tend not to change very much in the short term. So there's a valuable distinction that can be made between chronic and acute, but one cannot extrapolate that from saying you can take all the acute causes and distinguish one acute cause from the other based on a changing pattern.
Which is better to use, a relative change, or should we pick an absolute change in the troponin value?
Part of this is assay dependent. With assays that don't measure normals, we have no way of measuring biologic variation, and the only thing we can use is, are there differences that are analytically different? And that's roughly 3 standard deviations of the variance around the measures, which for an assay, for most troponin assays, once the values are elevated, not at the very low levels, but once the values are elevated, is about 20%. So a 20% change is significant analytically. With very high sensitive assays, we now know that you can measure biologic variation and add it to analytic variation, and that gives you a higher percentage. And that's been tested with high sensitivity assays. And the problem is that it appears that clinically important increases can be substantially below what we measure as conjoint biologic and analytic variation. And what that really means is that we will use those criteria. We will, if they're below the biologic and analytic variation, we will include some patients who get there just due to variation alone. So we will improve our specificity to some extent in one sense and lose some in the other because of the inclusion of normals. This is where an absolute change may be helpful. The data would suggest that absolute changes may do better. If you look at early patients, it doesn't appear that that's the case. But perhaps late patients, it looks like absolute changes may be better. And that may be because once the curve and the values start to rise, they can't continue to go to astronomical sorts of lengths. So a 50% change of a very high value is too high. And in that circumstance, that's where the data suggests that an absolute value, which would have to be assay dependent, may be better.
What about using the higher sensitivity of these assays to more rapidly rule out patients? The standard rule out protocols now typically take anywhere from 6 to 8 hours. Using these more sensitive assays and using rates of changes, can we exclude MI in a much more rapid fashion? And if so, how fast?
Well, I think that there's a yin and a yang to this that we have to be careful about. Most of the studies that have been done heretofore use as a gold standard the previous relatively less sensitive assay. And if you do that, you say the new sensitive assay detects all those MIs in 3 hours and you're all done. And therefore all the rule outs are done. But you know that with the more sensitive assays, you also detect an additional group of patients. And that additional group of patients is the subtler group. And it takes longer for their elevations to manifest themselves. So we need to be very careful. In a recent study, which I've participated in with a group from Spain, we've suggested that when you include the new MIs, that actually you go back to 4 to 5 or 6 hours from the point of view of detecting all MIs. Now, that's ruling in. I think there's some strategies for ruling out with high sensitivity that will be helpful. Richard Bodie and I, Richard's from the UK, have shown that if your value with a high sensitivity assay is very, very low, that when you first present, which occurs in about 25% of patients, that you can confidently exclude myocardial infarction in almost everyone. Similarly, if patients come in and they're 6 hours from the onset of their chest discomfort, and you can make that determination reliably, because as you well know, Mike, that's a tough decision to make sometimes. But assuming you can, then one lack of elevation also excludes MI. And if you start adding them up, now we're talking about maybe 40 or 45% of patients. So there are some strategies, and it may turn out eventually that using the delta at very low levels will help us as well, but that's not been probed as yet. So I think that there are strategies. I think we just have to be careful and urge our readers to be very careful in reading the papers carefully so they make sure we're talking about all the MIs and not just the subset that is detected with insensitive assays.
Well, Dr. Jaffe, thank you so much for that excellent discussion and for joining us today. For more information, please visit the biomarker community at cardiosource.org. Thank you.